Hello, good evening, and welcome to the open evening. Um, this is the Herts Essex Fertility family, and I know I've got quite a few of you who have already joined, and there are others who are trying to join, so very welcome once again. Right, so let's get this presentation going. So what's on the agenda today? I will take you through this presentation, and after that, we've got a Q&A. Rather, we've got a question answer session which is going alongside. So if you see on your Microsoft Teams, there is a Q&A button. You can, as I go along, if you have questions popping up, please go ahead and post those questions. I've got my colleagues, and a bit later, I will join them in answering those questions. And towards the end, I will also take you on a virtual tour of the clinic. Please do stay with me till the end because we've got a special discount offer that I shall reveal at the end. So once again, a very welcome. And with me tonight, so I am Praveena Pai. I'm one of the consultant gynecologist and fertility specialist. And with me this evening, I have Jackie McAdam, one of our senior fertility nurses, who is taking the question answers alongside this presentation. I also have Mana Marks, our marketing and wellness chief, who has put this whole thing together. So once again, very welcome. Let's get started. So a little history about our clinic. So the clinic was founded in 1989. We've got over 35 years of experience with more than 8,000 babies which have been created. The good thing about our clinic is that all the procedures are performed under one roof. So right from you entering, the nurse assessment, you're seeing the consultants, the egg collection, the embryo transfer, the IUI, whatever procedure that we have planned for you. And then you can pick up your medication also from the pharmacy, which is under the same roof. So it's a state-of-the-art, purpose-built clinic with everything within the premises. So what are the services that we provide? So we've got fertility assessments. We've got gynecology screening. We deal with egg and sperm donation. We've got surrogacy services. In fact, we're one of the leading clinics in the country offering the surrogacy service. We undertake procedures such as intrauterine insemination, IVF, ICSI, PICSI. I'll go through these a bit more in detail. We also have fertility preservation. So somebody's interested in egg freezing, sperm freezing, perhaps creating embryos and freezing for future use. We also have some additional treatments like PGTA, PGTM, PGTSR. So this is pre-implantation genetic screening of embryos before using the embryos. And again, I'll touch upon these a bit later. We obviously do pregnancy scans. So this could be standalone pregnancy scan. Someone has conceived naturally and they want a reassurance scan before they get one on the NHS. Or of course, they've had treatment with us and then we will give them the first pregnancy scan with us before we send them down the antenatal route on the NHS. The fertility assessment comprises a couple fertility assessment, which includes 2 visits. So you come in, you drop off the semen sample, you drop off your blood tests, you have a pre-assessment with one of the nurses, and then once those blood test results and the semen analysis results are available, one of the consultants will then see you. There is a scan which is involved to look at the pelvis a bit more in detail, and then we'll put all the results together and have a chat with you. So that's a couple fertility assessment. It could be a female fertility assessment, whereby the female wants to have an understanding of her ovarian reserve, perhaps her fertility prospects. So there is that appointment. Again, it involves 2 visits. Or it could be just a male fertility assessment whereby the male comes, drops off a semen sample, which then gets assessed, including a special test called hyaluronate binding assay, which tells us about the sperm maturity. This is not something which is done in every clinic. And once we've got the results, there is a call from the embryologist to discuss the results. We do take pride in the fact that we've got some excellent machines. We offer 3D ultrasound assessments and 3D ultrasound scans in along with a saline infusion. As you can see, a saline infusion, a sonogram, is a very fine or very refined way of picking up very minute problems in the uterine cavity. Like you can see here, there's a polyp, which just on a 2D scan may not even become visible, but thanks to saline infusion, providing us the contrast, and a 3D imaging done along with that is able to pick up those tiny polyps or fibroids, which could be the reason why an embryo is not implanting, for example. So we offer a saline infusion sonogram, and along with that, if you also then pass a dye to look at the function of the tubes, that is known as a high COSY. Okay, so we do offer a CIS and a high COSY as a part of the assessment. Before any sort of treatment is started, there is obviously you want to put your best foot forward. You want to get as fit as possible. We have a dedicated page on our website called fitforfertility.com, where you will have lots of advice about how to enhance and become the best version of yourself, if you like, before you commence treatment. Okay, so I would encourage you to go and have a look at that. So what's the treatment pathway like? So let's say a couple or an individual calls the clinic saying that he or she is interested in commencing some sort of fertility procedure or assessment. What then happens is once you get in touch with the clinic, we will initially get you some fertility consents. So there are some login details which are sent to you. You are encouraged to complete some forms online, and that is providing us with information to go ahead. Alongside that, we book a pre-assessment appointment. So this pre-assessment appointment is in person. You come and meet one of my nurse colleagues who does certain observations, such as, you know, your weight, height, BMI, your blood pressure. Blood tests are organized. So for females, we look at ovarian reserve by doing a blood test known as AMH, which stands for anti-Mullerian hormone, and we also look at your thyroid functions. BMI, I just need to add a word here. The BMI assessment is crucial because if someone's going to have a treatment, particularly if it involves having eggs collected under sedation, it's crucial that we have that BMI under 34 before we commence the treatment cycle, because that's the only way we can ensure safe sedation. Semen assessment, so the male partner is encouraged to drop off a semen sample. So we've done the fertility consents, we've done the pre-assessment, and once we have all the results, a full consultation is then booked with one of the consultants. This is done via Teams. So we send the invitation out either the evening before or the morning of the consultation. And in this consultation, usually it's an hour-long comprehensive consultation wherein the consultant will have a look at all the assessments. So we look at your, your observations, so the BMI, look at your records. If you've enclosed anything done elsewhere, we have a look at those. We look at your fresh blood tests, look at the semen parameters, and then we go through all these in detail and then come up with a personalized plan as to how best can we help you achieve that pregnancy. This is followed by, we drawing up a plan, we sending out a letter. We also have a discussion about the costs involved in the treatment. Right, so once that's done, then a couple, let's say, or the individual decides we want to start the treatment. We commence that by doing some screening bloods. Screening is required for all patients. Screening includes infection screening for HIV, Hep B, Hep C, chlamydia, gonorrhea. Additional screening for the egg or the uterus providers includes the AMH, as I mentioned earlier, that's for ovarian reserve. We also look at rubella to see whether you're immune. We also look at your full blood count, ensuring you've got adequate hemoglobin to commence a pregnancy journey, and hemoglobin electrophoresis to find out if somebody's got a thalassemia or a sickle cell anemia. The results that it's important that we do these screening bloods as close to starting treatment, because these should be, so once the bloods are done, the egg collection should have happened within 3 months. That is the HFEA guidance. If you have done bloods elsewhere, as long as they have been done in an UK accredited laboratory, we're happy to accept them. So that's another thing that we are happy to go ahead, and if we can avoid bloods, by all means, get those blood tests results to us. So let's move on with the treatment options. So essentially, The treatment options include IUI, which is intrauterine insemination, or it could be a cycle of IVF, ICSI, PICSI, or of course it could be fertility preservation, it could be, egg donation, surrogacy, and so on. So I'm going to start with the intrauterine insemination. IUI is a procedure whereby the healthiest available sperms are introduced directly into the womb. Okay, it is used to aid pregnancy, particularly in heterosexual couples who have problems having sexual intercourse. So it could be either because of vaginismus in the female partner, or because of erectile dysfunction or premature ejaculation in the male partner. IUI is also a good way to achieve pregnancy in, let's say, same-sex female couples who are going to use donor sperms. And if they've got good ovarian reserve, then this could be a less invasive way of getting pregnant. All right, it's important that we've checked the tubes beforehand. So remember, I mentioned high COSI. It's important that we've done a high COSI and made sure that the cavity is looking good. At least one of the tubes is working properly, because here the fertilization has to take place in the tube, and that's important. So moving on with the IVF treatment, what does the pathway look like? Essentially, once we've done the consultation, we have drawn up a plan for IVF. You've done the bloods. We also do an appointment with one of the nurses called a TIA, a treatment information appointment, whereby you sit down again across teams, and the nurse will make sure that you've got all the legal documents correctly signed, all the consents are ready. So once that's done, we commence the treatment, and the treatment actually involves the female partner coming in for a baseline scan. So it starts with a period. Okay, so the female partner coming in for a baseline scan on day 1, day 2, or day 3 of a period. On that baseline scan, what do we do? So we would have drawn up a plan. One of the nurses, or even maybe a consultant, if you happen to be on my scan list, I'm going to look at that plan. I'm going to look at the baseline picture of the ovaries, making sure there are no surprises like cysts or any such things. And then we will teach you how to do these injections. So these are hormonal injections, which are very fine subcutaneous injections, which you will be taught to self-inject into your tummy. And these will begin on day 1, day 2, or day 3, usually, of your cycle. These hormonal injections stimulate the ovaries to because they've got follicles, and they encourage those follicles to start growing. Follicles are little balloon-like structures in which the eggs are present, and the growth of follicles is encouraging those eggs to grow within. So these injections usually happen in the evening, maybe 7 or 8 p.m., and they continue on a daily basis for about 10 to 12 days. So up until 2 days prior to the egg collection. What do we expect with these injections? I mean, the vast majority, these injections are very well tolerated, although they are hormonal injections, but you have to be mindful that, there could be small side effects like headaches, moodiness, breast tenderness, bloating. In some women who've got polycystic ovarian syndrome, particularly, we're quite careful because they are very prone for a situation or condition known as ovarian hyperstimulation syndrome, where we use a very specific protocol. We monitor the cycle very carefully with scans. We use specific triggers so as to reduce the risk of OHSs the best we can. Okay, so here we've started the journey. We then bring you back for a couple more scans to keep an eye. As I said, we want to monitor the cycle carefully. On your check scan, so when we bring you in for the next scan, what do we want to see? So we want to see a picture like this. Okay, so this is the picture, an ultrasonographic picture of an ovary with lots of these dark circles, which are the growing follicles. Okay, so that's a nice picture. So ultrasound scans to determine what we also want to determine with this scan is, are we getting a response, number one? And is this a good time to now introduce another injection in the mornings, which is known as an antagonist? And the aim of giving that injection is to prevent you from ovulating prematurely. All right. So generally with this scan, we get an idea, okay, looks good, let's start. We will then start the antagonist, and that usually starts from day 5 or day 6. Okay, that's to prevent you from ovulating prematurely. We continue monitoring the follicular growth. Simultaneously, we are also monitoring the endometrium, that is the lining of the womb, because if someone's heading for a fresh embryo transfer, we want that lining growing simultaneously to get ready to receive that embryo. Each scan that is done is then followed by a consultation with the nurse. So if you've had a chance to chat with the consultant, for example, but you still have some questions, certain queries about injections, etc., every scan is followed by a nurse just a follow-up with a nurse. All right. So yeah, so the journey continues. And we come to this is what I was mentioning. We want to see a simultaneous, lovely endometrium getting ready to receive that embryo. All right. And then comes the final scan. So at the end of maybe 10 to 12 days of injection, we find that on the final scan, we find that most of the follicles are looking lovely. They're looking good size, mature, ready. Okay, so that tells us, okay, now this is the time to get the individual ready for an egg collection. So how do we get that final burst of maturity? We do that by giving a trigger injection, which is usually HCG. But in people who are more prone for HSS, we might change that trigger to something known as GnRH analog. Okay, in this appointment, on that final appointment, when we are placing somebody for egg collection, you'll have a very detailed chat with a sonographer as well as a nurse who will give you very extensive instructions on how to get ready for the egg collection. When do you need to come in? How many days of abstinence does the male or the sperm provider have to have, and all the nitty-gritties there. Forgot to mention something. We do have something known as Salve app, okay, and I think it was there in one of the slides. It's a beautiful app which we get you to download even before the treatment begins, because that comes as a so this app gives you reminders about your medication. It also works as a good tool to have messages. So if, late in the evening, you suddenly remember, oh my God, I forgot what time was I supposed to take the trigger, or how was I meant to do it? You could have a quick chat with one of the nurses, all right? So Salve app, again, something which is loved by most of our patients. Right, so comes the day of egg collection. All right, so what happens on so after the trigger, generally between 36 to 40 hours is when we would have timed the egg collection. Both, let's say, two individuals, if they're coming for the egg collection, they're invited inside the recovery bay. You get a chance to meet the anaesthetist, because the egg collection, as I mentioned earlier, we offer under deep sedation. Okay, baseline observations are done. The male partner goes away to provide us a fresh semen sample. The female partner is now wheeled inside after emptying her bladder, wheeled inside the operation theatre, and then she is put to sleep for about half an hour. Egg collection procedure takes about 20 minutes, 30 minutes under sedation that's been provided. It's a transvaginal procedure. Once the procedure is finished, the patient is now wheeled back into the recovery bay. Okay, once she's come out of the anesthetic effect, the partners with her, let's say I'm the operating surgeon that day, I will come and have a chat, okay, and then I'll be able to give you the initial egg number. Okay, so generally speaking, the couple is in the clinic on the day of the egg collection for maybe 2-3 hours, okay, and then we let you go home. What do you expect when you go home? You will clearly be a bit sore. You might have a bit of spotting. Egg collection, generally a very safe procedure, but there is a tiny risk of infection and bleeding. So we'll give you some antibiotics to take with you as well. Righty-ho. Now I'm going to give you a little peek into what happens in the laboratory. Okay, so we've got the eggs, we've got the sperms. What happens thereafter? So the day of the egg collection is known as day 0. All right. Let's look at the day 0. So if somebody has come for fertility preservation, so, there's a lady not interested in starting family just yet, but would like to freeze her eggs. So this is the social egg freezing that we offer. It's a reproductive technique to preserve fertility. Earlier, women could freeze their eggs for 10 years, but in a recent parliamentary consideration, they have increased that limit to 55 years. The quality of eggs, when they are stored, the younger the age, the better the quality, better the competence, and better the ability of these eggs to thaw, fertilize, and give us a competent embryo. Okay, so that's one of the little takeaway, but at no age really, do we say that you can't freeze your eggs. So there will be a chat based on what is the age, what is the reserve, what number of eggs should you be looking at freezing. All right, so egg freezing, maybe, as is usually the case, is maybe for social reasons. But we also find it's, in situations where somebody is threatened to go into early menopause, maybe because of chemotherapy due to cancer, or because of surgery, sometimes because of, severe endometriosis, where there is, everything else has been tried and they need to go ahead with the bilateral salping oophorectomy, that is removal of both the ovaries. They may want to first have the eggs frozen. counseling is provided before this is undertaken. So all this is happening on day 0. Okay, let's say it's not an egg freeze. Let's say there is a couple who's come through for a cycle of IVF. So what happens once the eggs are collected? The sperm that has been provided by the male partner is now looked at in detail by the embryologist. And if the semen parameters are looking completely normal, then we go ahead with a process known as in vitro fertilization or IVF. And essentially what that means is all the eggs that have been received through the vaginal egg collection procedure are now left in petri dishes surrounded by millions of sperms, and then they're left undisturbed. 24 hours later, the embryologist then go and have a look and see how many of these have got fertilized. So this step is known as IVF. ICSI, on the other hand, is a procedure whereby the embryologist will want to give the sperms a hand or a little help. And ICSI stands for intracytoplasmic sperm injection. So if on the day of the egg collection, they find that the semen parameters are not quite meeting the strict criteria laid down by the laboratory, there is a little fear that if we were to leave it to IVF, we might not get a good enough fertilization rate. And in those instances, the embryologist will look under the microscope, they will pick up the best sperm, and each mature egg is then injected with a sperm. Okay, so ICSI might be beneficial in those who've got low sperm parameters like low count, motility, lots of abnormal forms, or if you find that there are no sperms in the ejaculate. You know, we do have men coming through with a condition known as azoospermia, and we need to surgically retrieve the sperms from the testes. These are very precious. We need, and they're not suitable to, for IVF. They will be used in ICSI. Sometimes men have got antibodies which cause clumping of the sperms, which then comes in the way of these sperms fertilizing the eggs, and consequently ICSI becomes the method of the choice, if you like. And if somebody has had previous IVF cycle and unfortunately resulting in total fertilization failure, then it's a given, then the next cycle will be ICSI. So let me take you into this little video, which even now fascinates me. So this is how an ICSI procedure is carried out. You can see there is that needle, okay? And what it's trying to do is it's looking at various sperms, okay? And we're trying to see if we can see a really good, motile, normal-looking sperm. And once the embryologist looks and finds there is one which is looking really good and healthy, what we then do is we just snip off the tail, which sounds brutal, but that's the way it's done. And then we aspirate, suck it into this little pipette. There we go. And now the aim is to go towards the egg. So you'll see in the next screen, there is a pipette holding this egg. All right. And we've got the sperm holding needle. This is going to now penetrate the zona. You can see the sperm is placed beautifully here. And we penetrate, go through the egg, go right into the cytoplasm, suck a little bit of the cytoplasm, and then just very gently expel the sperm into the cytoplasm. That's the intracytoplasmic sperm injection for you, and then very gently withdraw. So that's the ICSI procedure. And last but not the least, we've got PICSI, that's physiological ICSI. So if you've done a hyaluronide binding assay and we find that the maturity of the sperms is less, then we do a special a test whereby we can actually go and select the most mature sperms in the semen sample and then do an ICSI, and that's known as PICSI. Okay, so once day 0, we move on to day 1. What do we want to see? We want to look for fertilization. A normally fertilized egg looks like this. You can see a beautiful exterior and you can see 2 pronuclei, okay? And if it's looking a beautiful normal 2 pronuclei structure like that is when we move it into an undisturbed blastocyst culture, okay? Occasionally we may have abnormally fertilized eggs which don't give us pregnancy, then these are not used. So you will get a fertilization 24 hours later after the egg collection. You can expect a call from the embryologist to tell you how many of the eggs have fertilized. And as long as we've got 3 or more which have fertilized, we then leave them in an undisturbed culture to develop to the blastocyst stage, and you'll be given a date and a time to come in for the fresh embryo transfer. Okay, I will skip these particular points because otherwise it becomes too much. Day 5 is when most of the embryo transfers take place. So embryo transfers, the good thing about our clinic is we offer embryo transfers 7 days a week. That way we maximize your chances of pregnancy. We don't try and confine it to the weekdays. Okay, you are given an opportunity. So you're given a time and a date to come in for the embryo transfer. When you come in, you are asked to come in with a slightly full bladder because we do what is known as ultrasound guided embryo transfer. You're given an opportunity to look at the picture of the embryo on a screen before it gets loaded into the catheter and is placed very gently inside the womb. Embryo glue is an add-on that our clinic offers. It's offered to all patients. It's a transfer medium which mimics the conditions in the uterus, and there are studies showing that the use of embryo glue before the transfer does help with implantation rates. Okay, and as I mentioned earlier, we do offer certain additional things that can be done to try and select or optimize the pregnancy outcomes. And one of the ones which you probably have heard is PGTA. PGT stands for pre-implantation genetic testing of embryos, and the A here stands for aneuploidy. So if a cycle is not, in the vast majority, if we get a failed cycle, as in we get a negative pregnancy test result, or there was a positive pregnancy test, but by the time the individual comes for the first scan or the second scan, we find that the pregnancy has stopped growing, resulting in a miscarriage. Now, studies have shown us that in most of these cycles, the fault lies with the embryo. This embryo was very likely chromosomally abnormal, did not have what it takes, okay? But thankfully with PGT, we now have this ability to be able to biopsy the cells. And what do we do in this? So if you can see, this is a blastocyst, all right? Here, clump of cells is known as inner cell mass, which is going to form the baby. And all around this, a single layer of cells, which is called the trophoectoderm, which is going to form the placenta. In a PGT sample, what the embryologists do is they make a very tiny hole, okay, and then they suck out maybe 5 to 8 cells from the trophoectoderm. And the rationale is that the trophoectoderm reflects the genetic constitution of the inner cell mass, so we don't want to disturb the inner cell mass, but equally we want to get enough information. So these cells which are now sucked out are now sent to a specialized laboratory for genetic testing. Results come back in a couple of weeks, and the results might then tell us, okay, this is a perfectly normal euploid blastocyst, or it's an abnormal complex aneuploid blastocyst, or it could be a mosaic, which means it's got both cell lines, and we can talk a little bit more about what do we do with those. Okay, PGT can also be used to pick up monogenic, to screen for single gene disorders like cystic fibrosis, BRCA, Huntington's disease. All right, and equally it can be used for picking up structural rearrangements, which do result in higher risk of miscarriages and so on. All right, so our clinic does offer all these services, and we've got embryologists almost on the clock who can do these procedures. And then comes embryo freezing. So let's say we've done a fresh transfer. A couple has come in, we've done the fresh transfer. 1 in 4 couples will also have spare embryos to freeze. So we do any embryos that have not been transferred and are of a suitable nature to be frozen, get frozen. Okay, this includes embryos that were biopsied and all the embryos of people who are not planning to undertake embryo transfer. So there could be women who, sometimes we advise not to have a fresh transfer. So let's say we've got women with polycystic ovarian syndrome, they produce a prolific number of eggs, they have features of OHSS, not a good time to do a fresh transfer. In those situations, we allow all those fertilized eggs to develop to the blastocyst stage, and then we freeze everything. And this is known as elective freezing of embryos. Right, so moving on with the IVF treatment, what happens? What we want to reach is this stage where, we do a pregnancy test about 16 days after the embryo transfer, and voila, we've got a lovely, strong, positive result. And if that's the case, you will, if it's a urine pregnancy test, which is what we do after fresh transfers, you will let us know the result, and the nurse will then book the first scan, which is usually done about 3 weeks from the blood test or the urine pregnancy test. That is the first scan, which is a 7-week scan. And what we want to establish in that scan is that this is a good pregnancy. It has lodged in the right place and it's doing the right things. We've got a beautiful yolk sac, as you can see here, in a lovely pregnancy sac. We've got a beautiful fetal pole and a good strong heartbeat. So once we've established it's a nice, strong, viable pregnancy, we'll give you advice on how to come off your luteal phase support. Okay, so you were taking the cyclogen pessaries, let's say, and we will gradually ask you how to drop these off. And at that point, we kind of say goodbye and send you down the NHS route for your antenatal booking. So that kind of finishes an IVF/ICSI or a PICSI journey. We also in our clinic offer egg donation and sperm donation. All right, so if someone wants to just altruistically, from the goodness of their heart, want to come and have, donate eggs, we can take them through the stimulation cycle. Okay, egg donations are an important source of joy for someone else who probably don't have their own eggs. It could be because of age-related decline in fertility. Some women reach early menopause. Some women have lost the ability because of chemotherapy. Some women have tried a few cycles and they've realized that their eggs just aren't competent to give us a good embryo. There are those who are born congenitally without ovaries. And of course, sometimes we have same-sex male partners coming, and they would like to use donor eggs, use their own sperms, create embryos, and then use that in a surrogate to accomplish a pregnancy. All right. So egg donation, we do have a dedicated egg donation team in our clinic. Equally, sperm donation is an important method helping many create families. So it could be because some men don't have sperm production, azoospermia, as I mentioned earlier. Some men have lost the ability to produce semen or sperms because of chemotherapy, genetic disorders. Single ladies would like to use donor sperms. So donor sperms are an important source of bringing them joy. Same-sex couples. So we do have, just like we have an egg bank, we have a sperm bank. So any couple who would like to use donated eggs or use donor sperms, we have dedicated teams looking after both these. Moving on to surrogacy. Now, we've performed more than 355 cycles since 2012, which is when we started surrogacy. Again, there is a very enthusiastic, dedicated surrogacy team in the clinic. What happens is once, let's say, a couple contacts us, then they have a full consultation with the consultant, as does their surrogate. So the intended parents and the surrogate both have an in-depth consultation with the consultant and implications counseling with one of our counselors before they commence treatment. Many cycles also includes an egg donor. As I said, if you've got two male partners, they would want to use their sperms, donor eggs. We facilitate that because we've got an egg bank, and then we encourage them to, or rather help them find a surrogacy agency so that the embryos which are so created can be transferred into a surrogate. So we do, look after the surrogate as well. We have a full consultation. We assess her womb. We do the embryo transfer, and we take her all the way till the first pregnancy scan. We also have these single people using their own gametes to create embryos and then use a surrogate to accomplish the same. Surrogacy can be of two types. It can be a host or full surrogacy, or a partial or straight surrogacy. And what we usually, most clinics in the UK do, is a host surrogacy, whereby it's only the womb. So the woman is just lending her womb, and there is no genetic connection, as in she's not also providing the eggs. So our clinic does offer NHS-funded fertility treatment. So how to access NHS fertility? We are in partnership with 3 main ICBs, the Mid and South Essex, North Central London, and North East London. Your ICB is determined by the location of your GP and not your home address. So if you want any further information, please visit our NHS webpage and see if you can qualify through any of these ICBs. The North East London ICB includes Barking and Dagenham, Havering, Redbridge, Waltham Forest, City and Hackney, Tower Hamlets, and Newham. The Mid and South Essex ICB includes Mid Essex, Castle Point and Rochford, Basildon, Brentford, Thurrock, and Southend. North Central London ICBs include Barnet, Camden, Enfield, Haringey, and Islington. So, as I said, we are doing a lot of NHS cycles. So by all means, contact your GP and see if that is something which is feasible for you through our clinic. You will find that some of the couples don't qualify for NHS funding, but there is, no reason to get despondent. There are other ways in which our clinic is trying to see if we can bring down the expenses. So the couple of programs that we do with that aim in mind is one is the egg share scheme and the other one is a sperm share scheme. And there are more details available about it through our website. So Valentine's Day is tomorrow. And as I mentioned, we do have a special Valentine's offer. So a new consultation, if you book a new consultation before 28th February, that is a couple of weeks from now. So within that time, a full consultation, which normally costs £250, will be available to you at 125. Do note, it does not include the blood tests and the semen analysis. This is the cost for the new consultation alone. All right. So other than the NHS, the sperm share, the egg share, we also have fertility funding options. So we have partnered with a couple of organizations, Access Fertility and Assured Fertility. So again, we've got lots of information about that on our website. Please have a look and see if that is something you would like to go with. Any questions, you can talk to our finance team. Wellness at Herts Essex is a very key and an important aspect of all the care that we provide, because we understand that treatment for infertility is a daunting and a very arduous journey. So you'll find that not just the counsellor that we have, and you've got counselling sessions available as a part of the treatment, but every individual that you meet in the clinic, you'll find that empathy. Okay, we never say that we are going to 100% promise a baby to every individual or every couple that walks in through the door, but we want to make this journey as less traumatic as possible, and make it as positive as possible. So wellness at Herts will always remain a very key and a sort of central theme for that. Moving on to, again, fitness and diet. We do have Alex with us, who is a dedicated dietitian looking after diet and fertility. So again, we've got her details on our website. She offers one-to-one consultation. She's very passionate about the science behind nutrition, particularly with fertility in mind. So by all means, if you think, yes, I need a little bit more information or probably input about this, do contact her. So why us? With over 35 years of experience, and as I said, about 8,000 plus babies created, it's a very passionate and dedicated team that will be looking after you. We have 7-day-a-week lab service. As I mentioned, we do embryo transfers all 7 days. We've got electronic witnessing system, making sure there is no mixing of gametes at all. There is support throughout your treatment. You've got SalvApp. You've got, any minute of the day if you feel there's something which is not clear. Plus, you just have to message us. Okay. There's emotional support for patients, and of course, we've got free parking, and we've got a beautiful canal flowing next to it, and lots of couples and patients have a lovely walk and find it very soothing. So yeah, it's a nice location. So thank you very much for staying with me till the end of the presentation. Marna, I think, is just putting up a SurveyMonkey link, and we'd really appreciate if you could give us a feedback, anything, pluses, minuses, they do go into improving these presentations for future. Follow us on the social media. So we've got, you're there on a lot of these platforms. And yes, so these are the details if you want to book an appointment, and I'm sure Marna and the team will get in touch with you again with all these details via SMS tomorrow, so that you can just pick up a phone, talk to us, or send us an email on the enquiries at hertsesexfertility.com. New consultations usually are available within 1 to 2 weeks. So yeah, if you are interested to use the deal that I've mentioned, just pick up a phone and we'll try and accommodate that new consultation ASAP. I'm sure you have questions, and I'm sure Jackie has been dealing with the question and answers, and I'll be joining them soon. But before I leave you, once again, a big thank you for attending the open evening. I'm now going to share a link, and I'll take you on a virtual tour of our clinic. Thank you very much, and have a lovely evening. Let me share. Sorry, just bear with me. Oopsie.